So we're going to talk about determining progression in keratoconus. My only financial disclosure is that I do some consulting with Oculus. So as we know, there are many modalities that have improved over time, really to improve patients' vision with keratoconus. But there still remains one key treatment to stabilizing the cornea, and that's corneal crosslinking. But with this advent of crosslinking, it's become even more important to determine which patients are progressing and to capture those patients as soon as possible so that we can stabilize them. So if we look back at the multi-center FDA pivotal trial, how did we define progression of keratoconus? Basically, patients had to have steepened by a diopter or more their K-steep. Manifest cylinder had to have increased by a diopter or more, or the spherical equivalent had to worsen by about a half a diopter over the course of 24 months. But as we know, these metrics are very difficult to capture in keratoconic patients, especially as those patients become more severe over time. We could have a patient in the office with keratoconus and sometimes capture different measurements in hour by hour when it comes to a manifest cylinder or spherical equivalent. And we actually looked back at over 1,000 keratoconic eyes that we've treated, and what we found was pretty surprising. 40% of those eyes were hyperopic or metropic when it came to sphere, and 40% of the eyes had a mixed astigmatism or no astigmatism at all. And this ranged across any age group and any severity of disease. So clearly, refraction alone is not enough to determine progression. We then looked at average metrics of the cornea and found that on average, K-steep was 8 diopters flatter than Kmax. When we looked at this more closely across severity of disease, even mild to moderate cones, so 50 to 55 diopter cones, the K-steep was about 47 diopters. So easily you could miss that as keratoconus and pass that off as normal. In fact, when we looked at the correlation, it was cones that were 65 diopters or steeper that were the first to really correlate with K-steep, K-flat, or K-mean. So clearly, those curvature measurements are not enough to diagnose keratoconus, let alone monitor keratoconus for progression. So as we know, tomography has become the gold standard to diagnose patients and follow them for progression over time. And the metric that's clearly used the most is Kmax. Most of the literature reports on Kmax to determine efficacy of treatments, progression of disease. And this was a patient that we saw in our clinic, a 16-year-old female who we saw for their initial visit, their Kmax was 48.9. And actually, when she came back for her crosslinking, only 3 months later, her Kmax had steepened by almost 5 diopters. She was 54 diopters, so a very aggressive case of keratoconus. But as we'll see in some of the other examples that we're going to look at, Kmax alone still can't be enough of a metric to follow patients for progression. It's still only a snapshot. It's still only 1 point on the cornea. So we've begun to focus particularly on the thinnest point of the cornea and the 3 millimeters around that point to determine the change in keratoconic patients over time. I have to credit Dr. Bellen with a lot of the work in looking at this area. But if we take this example, this patient would be pretty clear progression. If we look at the patient over the last 3 months at their axial curvature map, clearly steepened and they have inferior steepening. If we look at their front elevation maps, they've also have more elevation in the front, more elevation posteriorly, and corneal thinning, and we already know they steepen in Kmax. So this is a pretty clear case of a cornea which has progressed. And if we now look at the Bellen ABCD progression display, we can synthesize that data all into one screen. And the way this display does that is it focuses in on the 3 millimeter zone around that thinnest point, takes multiple metrics into a regression analysis, and then you can see how the curvature is steepened in the A, which is the anterior, the front portion of the cornea, the B, the posterior, the back portion of the cornea, and the thinnest point. And it can be compared to a normal population in green, but more importantly for us, it can be compared to a keratoconic population in red. And we can now look at that and say, well, is this patient progressing? And with 95% confidence, the 95% confidence interval, this patient's anterior curvature, posterior curvature, and thickness has all progressed between visits. There's a D-value, which also looks at vision, that has to be manually entered into the system and doesn't really give a confidence interval for progression, but it's still a metric that can be followed over time. So we performed cross-linking for this patient and followed them over the course of the next 2 years. And what you can see between 2017 and 2019 is that this patient had 3 diopters of flattening, which is what we like to see after cross-linking, right over the cone. And again, the ABCD analysis can be very helpful in following these patients after cross-linking. So if we focus in on the anterior, posterior, and thickness of the cornea, there's now a third population that has been analyzed in the Pentacam system, and that is a specific population that has been cross-linked to determine whether after cross-linking we're seeing progression. And the system sets your baseline at 1 year after cross-linking, and then once you have the exams that follow that 1 year point, we can then determine if they have progressed any further. So this patient, which we can see from their flattening, has not progressed in their anterior curvature, their posterior curvature, or their thickness according to the new cross-linking metrics. So now let's look at another case. This was an 18-year-old male who we saw in the clinic, and this is a comparison of their first visit and their visit 3 months later. So looking just at the axial curvature map, front curvature, there's no clear progression for this patient in their curvature. If we look at the Kmax numbers, which we've been generally using to follow patients over time, no real change in Kmax. Again, kind of working through our algorithm one step at a time, their anterior curvature hasn't changed. There's no inferior steepening. Their anterior elevation hasn't changed. Their posterior elevation went from 31 microns to 36 microns, so there's a little bit of additional elevation. Hard to know what that means. Is that relevant? Does that constitute progression? There's no additional thinning, and their Kmax, as we said, hadn't changed. So has this patient progressed at all? Based on our metrics, it's very hard to say that they have. For the most part, they have not. But if we pull up the ABCD analysis, and again focus in on the ABC component, it really gives us a nice way to synthesize this data and look at it more closely. And what you can see here is that that little change, that small elevation change that we did pick up by using the compare to maps, does pass the 95% confidence interval that is probably real steepening in the posterior curvature of the cornea. And while you might not cross-link this patient immediately, although there's an argument to be made that you could, you would definitely tell this patient that they need to be followed very closely. And we would tell a patient like this, they need to come back in no later than 2 to 3 months and have these measurements repeated. And if this pattern was the same or continuing to progress, we would absolutely recommend doing cross-linking at that time. So here's a case of an 18-year-old where we're kind of not sure which way that they're going, but they are young, they have a aggressive time frame for their disease, and likely we're picking up an earlier progression with this ABCD analysis. So shifting to more severe cases, and how do we look at a more severe case and try to determine whether or not they're progressing? So again, focusing in on the metric that we've spent a lot of time on, which is the Kmax, this patient was seen in 2016, and now this is their map from 2019. If we focus in on the Kmax again, 77 in 2016, 78.7 in 2019. So this to me would look like, if we were just looking at that number, they've progressed. They've progressed by 2 diopters. They probably need cross-linking. Their thickness actually, although the severity of their disease is significant, their thickness does meet the criteria to have cross-linking done, and that's what we should talk about. But if we look more closely at the numbers and focus in on where Kmax is, the point of Kmax, you can see that it's actually changed over time. So Kmax was measured very centrally in 2016, and more peripherally, you can see on the y-axis, -2 now, so in about a 4 millimeter zone, it's being measured in 2019. So this is an easy metric to miss. It's an easy thing to gloss over, but the point of Kmax has clearly changed in this case, and at least we have to be thinking that maybe something else is going on here. This isn't traditional or typical progression. So again, working through our algorithm, if we look at the anterior curvature more closely, we see that there is inferior steepening. So we could consider that possibly this patient has progressed, but there's also this kind of atypical central flattening that we're seeing over that period of time. So there is inferior steepening, but not totally consistent with what we would normally look at and say this is definitive progression. If we look at the elevation map, there's no change at all. There's no change in the anterior elevation. Looking at the posterior elevation map, no change in the posterior elevation. But there is corneal thinning, and pretty significant corneal thinning. And so is this progression? Their Kmax has gotten worse. So 3 out of 5 of our metrics here would suggest that this was progression. Again, let's kind of focus in on their ABCD analysis. So if we focus in again here, what we can see is that the curvature change compared back to 2016 really hasn't changed much at all. If anything, we're picking up that around the thinnest point, they've had flattening, which is what we saw on that axial curvature map. And the only thing that we're truly picking up here is that the cornea has thinned. So this would be very atypical for traditional progression and just traditional steepening of the disease. So we can pull in another map that can be very helpful when it comes to the Pentacam and compare our densitometry measurements. And if we focus in on the difference, and particularly right in the center, you can see there's a hot spot right in the densitometry. The densitometry has increased right in the center. And again, looking at our axial map here, that area is exactly where we're seeing the flattening. So this patient has really had increased corneal scarring over time. And whether or not that patient now needs to be cross-linked is debatable. There's not clear progression. Their disease has gotten worse. They've had scarring. But whether the cross-linking is going to help them at this point is much more debatable. And probably this patient can be followed. So what would have started with just looking at Kmax and saying, well, this is severe cone, Kmax got steeper, this patient has gotten worse, with a more detailed analysis, this is definitely not a typical progression. And particularly with the ABCD analysis, you now can synthesize all of that data on one screen. So you can look on that screen and say, well, their curvature hasn't changed in the anterior and posterior, and they have gotten thinner. Something else is going on here, and I need to look deeper. So one final case, I think everybody would agree that this is progression. And we can learn a lot from our patients that tend to be lost to follow-up over time. So this was a patient who was 35 when we had seen him in 2009, had mild disease at best, was lost to follow-up, actually saw our optometrist in 2017 who had asked him to come see us for a cross-linking evaluation. Took him until 2019 to finally agree to come back and see us. But clearly, I don't think any of us would argue that this patient has progressed since 2009. They now have definitive keratoconus. But does this patient need cross-linking? That's why they're now seeing us. They need to know if we need to stabilize them at this point. And so we have, instead of the compare to, we have a compare for analysis on the Pentacam, which allows us to look at multiple visits over time. And so this is the axial comparison to 2009. Again, clear progression. We can look at the comparison to 2017. Looks like they're still progressing. There's still some steepening there. Compared to 2018, again, steepening, more superior than inferior, so it would be pretty atypical for this to be traditional progression, but steepening is there. And then we can flip through the curvature, anterior, posterior, the thickness. But by the time we've gone through all of these different metrics, you can't even remember what you've seen at the very beginning. So this is a lot of screens to have to kind of click through to try to make a determination of when this patient has progressed and do we need to do any additional cross-linking. So again, we're going to pull up our friendly ABCD analysis. And clearly, as we all know, when we compare this to 2009, this patient has progressed. This patient is worse and they are steeper. But what I want to draw your attention to is the red circle, which is that we can change our baseline exam and see and compare it to the different visits to really see how this patient has progressed over time. So compared to 2009, he has definitely progressed. But when we actually change his value to 2017, which is really what I'm the most concerned about, because I know he's progressed since 2009, but he's 45, he's in a more stable phase of his disease, and now we're comparing back to 2 years before, he actually has not progressed at all. at least compared to our confidence interval, the anterior curvature again, the posterior curvature, and the thickness, none of them really meet the criteria of progression. So I'm comfortable telling this patient, please don't leave for another 10 years, but you can come back in 6 months and let's recheck how things are going. This patient is actually likely to get by without having cross-linking done, and they're going to probably do fine. So in summary, there's no one metric that we can use that's going to determine KC progression. And we've evolved over time from K-steep and refractions to Kmax, but really it's most important to look at that thinnest point in the cornea, to look at the 3 millimeters in particular that surrounds that thinnest point. And the ABCD analysis now really does that for us. So that progression display is looking at that point over multiple metrics and comparing it to a keratoconic population and to a cross-linking population. And the nice thing about it is it's worked in mild cases, but as we saw, it actually works in pretty severe cases too. And the most noise that we tend to see when we're trying to figure out whether patients are progressing are in those moderate and severe cases where you can see steepening up top or down below or on the side. And it's very hard to know whether those patients are getting worse. But now that we can kind of really focus in on where the disease is happening, where that thinnest point is in the cornea, we can say with much more confidence that this patient is getting worse or this patient can be followed. I also find that it's very helpful for patients because it's really clear to them. If you show them a noisy picture that has red and blue and green, they don't know what you're showing them. And it can be very confusing to them. It all looks bad. But if you can show them, well, here's where you were in 2017, and here's where you are now, and the bars clearly are going in the wrong direction, I find that the patients understand that very, very simply, and they're much more likely to understand the need for their treatment, the need for cross-linking. And on the back end, if you can show them that they're not getting worse, if I can take that 16-year-old who got worse over 3 months and show them 2 years later, you're the same, it's really, really helpful for them to understand their disease better and really kind of work with us in terms of their treatment plan. So I think we're getting definitely better at diagnosing progression. Our ability to diagnose it earlier and in severe cases has really improved, and that allows us to cross-link them and really stabilize their disease more efficiently than ever. So thank you.